Welcome to this Step 2 review on breast disease test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for breast disease and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the surgery and reproductive sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for breast masses, breast cancer screening, and benign breast conditions. Second, we will apply specific strategies for breast mass evaluation, cancer staging, and mastitis management questions. And third, we will master the next best step question format for breast imaging, biopsy decisions, and treatment of common breast conditions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the age-based breast mass split. When you see a question about a breast mass, the very first thing you should look at is the patient age. For women under 30, the boards want you to think about benign causes first. A well-circumscribed, mobile, rubbery mass is the classic fibroadenoma description. A mass that changes with the menstrual cycle and is tender suggests fibrocystic changes. The key imaging choice for this age group is ultrasound. For women over 30, the concern shifts toward malignancy. An irregular, fixed, hard mass with skin dimpling or nipple retraction should raise a red flag. The preferred first imaging study for this group is mammography. The boards consistently test this age-based imaging split, so train yourself to look at the age first before anything else in the question stem. Strategy 2 covers the breast cancer screening framework. This is tested constantly on the boards. For average-risk women, mammography screening begins at age 40 according to most tested guidelines. If you see a question about a healthy woman with no risk factors asking when to start screening, the answer is usually to begin mammography at age 40. For high-risk patients, the screening approach is more aggressive. If the question mentions a known genetic mutation or a significant family history, such as a first-degree relative diagnosed before age 50, screening typically starts earlier, around age 25 to 30, and includes both mammography and breast magnetic resonance imaging. Review the screening guidelines in your question bank and first aid to reinforce these age cutoffs. Now let us go through high-yield stem recognition. The first pattern is the breast mass stem. A woman presents with a palpable breast mass. The question will give you the age, the mass characteristics like mobility and borders, and any skin changes. Your job is to figure out whether to order ultrasound or mammography based on age, and whether to proceed to biopsy. The second pattern is the inflammatory breast cancer stem. You will see an erythematous, warm, edematous breast with podorange skin changes, but the patient is not lactating. Do not fall for the trap of calling this mastitis. The boards want you to recognize this as cancer and order a punch biopsy. The third pattern is the mastitis and abscess stem. A lactating woman with a warm, tender, red breast area, often with fever. If there is a fluctuant mass, think abscess and consider drainage. Continue breastfeeding and treat with antibiotics covering staphylococcal species. Let us work through our first practice question. A 23-year-old woman presents with a painless right breast mass she noticed 2 weeks ago. On exam, the mass is 2 centimeters, well circumscribed, mobile, and rubbery. There are no skin changes and no axillary lymphadenopathy. She has no family history of breast cancer. What is the most appropriate next step in evaluation? Take a moment to think about which answer you would pick and what clues in the stem are guiding your decision. Let us break this down step by step. Step 1. Spot the pattern. Young woman under 30 with a painless, well-circumscribed, mobile, rubbery mass. This is a textbook fibroadenoma description. Age is the most important clue here. Step 2. Apply the rule. The board rule is clear. For women under 30 with a breast mass, ultrasound is the first-line imaging study. Younger women tend to have dense breast tissue, which makes mammography less sensitive. Ultrasound performs much better in this setting. Step 3. Eliminate wrong answers. Mammography is the preferred initial imaging for women over 30, not under 30, so that is out. Core needle biopsy is premature because we have not done any imaging yet. Observation alone is not appropriate for a new palpable mass that has not been evaluated. The correct answer is B, breast ultrasound. Here is our second practice question. A 52-year-old woman has a screening mammogram that reveals a spiculated mass with irregular borders in the upper outer quadrant of the left breast. Physical exam reveals no palpable mass. She has no family history of breast cancer. What is the most appropriate next step in management? Think about what the mammogram findings are telling you and what the next best step would be before moving on. Let us work through this answer. First, read the question carefully. The mammogram shows a spiculated mass with irregular borders. These are highly suspicious features with a high predictive value for malignancy. This is not a wait and watch situation. Now, why does core needle biopsy win? Because we need tissue for histological diagnosis before any treatment can begin. Repeating the mammogram in 6 months would be a dangerous delay for a suspicious lesion. Breast ultrasound alone cannot give us a tissue diagnosis, and lumpectomy without a tissue diagnosis first is putting the cart before the horse. You always need pathology before you operate. The correct answer is C, core needle biopsy. This is a classic next best step question. Review your question bank and first aid for the imaging to biopsy decision pathway. Let us talk about benign breast conditions for the boards. Fibroadenomas are painless, mobile, rubbery masses most common in young women. Fibrocystic changes present with bilateral breast pain and lumpiness that fluctuates with the menstrual cycle. Intraductal papilloma is the most common cause of bloody nipple discharge in a premenopausal woman. The boards love that fact. Now, there are also benign conditions that can mimic malignancy. Fat necrosis can present as a firm, irregular mass with calcifications on imaging, which looks like cancer. The key clue is a history of trauma or prior breast surgery. Phyllodes tumor presents as a large, rapidly growing mass that the boards test as requiring wide local excision, not simple enucleation. Review the benign versus malignant breast mass characteristics in your first aid and question bank. Here is our third practice question. A 31-year-old woman who is breastfeeding her 3-week-old infant presents with a 4-day history of right breast pain, redness, and swelling. She has a fever of 38.8 degrees Celsius. On exam, there is a 3-centimeter fluctuant, tender mass in the right breast with overlying erythema. What is the most appropriate next step in management? Think about what the key finding in the physical exam is and how it changes your management before moving on. Let us walk through this one. Spot the classic pattern first. We have a lactating woman with breast pain, redness, fever, and a fluctuant mass. The fluctuant mass is the key finding. It tells you this is not just simple mastitis. This is a breast abscess. Now know the key distinction. Simple mastitis without a fluid collection is treated with antibiotics alone, and you continue breastfeeding. But when there is a fluctuant mass indicating a collection, you need drainage plus antibiotics. Antibiotics alone would only be correct for uncomplicated mastitis without an abscess. Stopping breastfeeding is incorrect. The boards always emphasize that continued breastfeeding or pumping is recommended. Mammography has no role in acute mastitis management. The correct answer is B, incision and drainage plus antibiotics. Here is an important test-taking pearl on breast cancer staging and treatment. The boards love testing whether you know that sentinel lymph node biopsy is the standard for axillary staging in clinically node-negative breast cancer. If the sentinel nodes come back positive, axillary dissection may follow. Tumor size, node status, and distant metastasis determine the overall stage. For treatment questions, the key concept is that breast-conserving surgery plus radiation has equivalent survival to mastectomy for early-stage disease. The boards will try to trick you into thinking mastectomy is always better, but it is not. Contraindications to breast conservation include multicentric disease and prior chest wall radiation. Review the staging and treatment algorithms in first aid and your question bank. That wraps up our breast disease test-taking strategies video. Remember to review the surgery and reproductive chapters in first aid and your question bank. Focus on the breast mass evaluation algorithms, cancer screening guidelines, and benign versus malignant characteristics we covered today. Visit roadmap2residency.com for expert tutors and residency advisors who can help you with your board preparation and match strategy. Please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next video.